when we start patients, when we decide on what therapies to deliver in the patient with metastatic castration-resistant prostate cancer, we know that in patients who are asymptomatic, who have a good performance status, who have a life expectancy greater than 1 year, what the guidelines might indicate is that that patient might be ideally suited for Sipuleucel-T, which again is an autologous immunotherapy. However, when patients progress beyond that, then again, you have to take a look at the patient's individual characteristics. You have to take into account all of his comorbidities, his functional status, whether he has heart disease, whether he has neurologic deficits, does he have a history of seizures, has he had a history of strokes, does he have significant cardiovascular disease, and make a determination, and is he symptomatic? Is he having a lot of bone pain? Because 90% of patients with prostate cancer metastatic will have bony metastases. Is he having worsening fatigue? So all those things will come into play when we determine what is the optimal therapy. So a lot of times we know that traditional cytotoxic chemotherapy, vis-a-vis docetaxel or cabazitaxel, a lot of patients do want to steer away from those because of the side effect profile of those medicines. They are associated with myelosuppression. They're associated with significant neuropathies. So again, people, if given the choice between an oral therapy, a pill, like abiraterone acetate or enzalutamide, versus an IV cytotoxic chemotherapy, they will pretty much try to go to a pill. Radium-223, again, an alpha emitter radiopharmaceutical, the indication for that drug is for patients with bony metastases who are minimally symptomatic and who have very limited soft tissue disease. So in this particular patient, he was elderly. He had really, I think by the time that he had progressed, he was already in his mid-80s. He had already failed androgen deprivation therapy, although we continue to treat patients with ADT, with LHRH analogs, because that continues to be part of the treatment scheme. The best choice for this patient, given his history, was really abiraterone acetate, which is 1,000 milligrams daily, taken with prednisone 5 milligrams BID.